Hi. Our first question is, what is your name and title? And what do you work on in terms of procedures or research?
Yeah, so my name is Sean Chow. I am a senior director in THV R&D. I work at Edwards Lifesciences. My company works on heart valves, and we replace heart valves through a transfemoral procedure. So that means we 90% of our procedures go through the femoral artery, and we crimp down a transcatheter heart valve and put it through the femoral artery and push it through into the aortic valve. And then we balloon expand that aortic valve into the native aortic valve. So it's called TAVR, transcatheter aortic valve replacement.
Great, thank you. And so, what is important to know about TAVR and aortic valve replacements, especially as an engineer?
Yeah, so Edwards also replaces valves surgically, and I know that the data is telling us that the patients can recover much faster with a transfemoral procedure where we don't have to open the chest. And I think that type of procedure is much better tolerated by patients. So I know patients who have had the TAVR procedure, and I also know patients that have had open heart surgery. And the TAVR procedure, patients go home the next day. So as soon as they wake up from their procedure, they can already tell that they feel much better and they can breathe. Is what most commonly patients say. I feel like I can breathe much better, like somebody like just opened up my airway or something. Um, they can feel that right away because they don't have all the trauma in their chest. Um, so that's a really great thing, is this style of less invasive surgery. I also know somebody else who had open heart surgery, and it took 6 weeks to start feeling like he could move around, and 6 months before he really started feeling back to normal again. So that procedure is a very slow recovery process. So I think that going through a femoral artery is just a really great way to go.
Thank you. And so you mentioned that open heart surgeries was what was historically done in the past. So what's the big difference you mentioned with the balloon to insert a stent through an open heart procedure versus, say, a transcatheter procedure?
Yeah, so normally in an open heart procedure, it's very invasive. The first thing is the most obvious thing. Obviously, you have to take a bone saw to to the sternum and spread the ribs open with a rib spreader, and open the pericardial sac. And then what they traditionally have to do with open heart surgery is they have to put the patient on what they call cardiopulmonary bypass, which means instead of the blood going through a heart, it's going through what they call the heart lung machine. This is a big machine that they'll basically take arteries and reroute them through this machine, arteries and veins, and reroute them through this machine so that the machine will oxygenate blood and send it to all the necessary places. So that's one thing that's really big, is this cardiopulmonary bypass. The other thing that's really big is just cross clamping an aorta to kind of make it so that the blood doesn't go all over the place. And then opening the heart, and then sewing a heart valve in, which this procedure, it's amazing how skilled the surgeons are, but still it takes hours to do this procedure where you're on bypass and even anesthesia for maybe 3-4 hours. So that's a very long surgery. whereas with the TAVR procedure, it happens through a very small incision in the femoral vein. Like a hole, maybe that big, or very maybe a little bit smaller, and then we put a sheath inside the femoral vein, and we use fluoroscopy to be able to see it, and then we track a wire, and then we actually what we call crimp a valve. So it's like it looks like a stent. It's a frame that has pericardial leaflets sewn to it. And what we do is we take that frame and we put it in our special crimper that makes it small so it can fit inside that very small incision in the femoral artery. And then what we'll do is we'll push it up through the femoral artery into the descending aorta, and then over the aortic arch, and finally into the stenotic aortic valve. And once we get that valve into position, then we take a balloon and we blow that balloon up, and then the valve will stick to the native valve, and then we'll pull the balloon out. This procedure, our corporate vice president, Larry Wood, likes to say, we can do a heart valve replacement faster than you can get your teeth cleaned. So that's something funny he likes to say. But truthfully, that whole procedure probably is 10-15 minute procedure once everything is all set up. So it's really good because patients don't need to go. Actually, we have patients that that get the procedure while they're awake. So that's a really exciting thing. You don't even have to go under anesthesia to get this procedure done. So the trauma of just getting a little hole in your femoral artery is something that you can. It's like you got a little scrape on your leg or something, and actually you got a brand new heart valve in 15 minutes. So just a really neat revolutionary technology.
That's amazing. So I know Edwards Lifesciences has gone through a few iterations of the Sapien and all the different devices that are involved in the TAVR procedure. What improvements have been made recently that have just come out here in 2022?
Yeah, so you're right. Edwards has made a lot of improvements lately. We've been doing this probably, I would guess, maybe almost 20 years now, where the first things that we were doing was just trying to make it smaller, right? It was hard to crimp it to the right size, and we had a lot of vascular complications, which means that we would damage the femoral arteries, and we would need to repair those femoral arteries. Vascular surgeons would have to come in and sew vascular conduits in and repair those arteries. Since we made it smaller when we went from Sapien to Sapien XT to Sapien 3, we've just gotten gradually smaller and smaller, from 24 French to 19 French to now we're in a 14 French expandable sheath. So that size just keeps coming down, and now our vascular complications are probably 5% or less. So that's really good. And I think that journey of getting the valve smaller was there were very difficult engineering problems, just because it's a big valve. To get something that's 26 millimeters down to fit inside a sheath that's like you multiply by 3, so roughly 5 millimeters in inner diameter. That's a challenge, because there's tissue and there's frame and there's all this other stuff. So but we knew that we had to do it for the benefit of our patients. Every time I would go into a surgery, and the vascular surgeon would be shaking his head at me, because it took so much work to repair those femoral arteries, and also it wasn't good for patients. So that was one thing that was really really tough. The other thing that we did was we fixed what we called paravalvular leak. And so what happens is with aortic regurgitation and aortic stenosis, what happens is the blood is backflowing um, back into the heart instead of all of it going into the aorta. So what the heart valve is supposed to do is it's supposed to open to let the blood out, and then as soon as the pressure goes down inside the ventricle, the tissue valve is supposed to snap shut. Um, and so in a stenotic valve, these valves don't close very well, and so the blood can backflow in. Um, and so we call that central regurgitation, or central hole, right? So the blood can leak back in. When we place our valves, sometimes we get central regurgitation, which is like you open up the valve and the leaflets don't quite close correctly. Um, well, we found that 99.9% of the time we didn't get central leak, but we actually got leak around the valve on the outside. So we call that paravalvular leak, right? And so we spent a lot of time trying to figure out how to prevent paravalvular leak. And it ended up, the solution was like, when you look back on it, it's like, no duh, that's a really simple problem. But it took a long time to figure out how to do that. And what we did was we just sewed a really fuzzy skirt on the outside that encourages growth and things to kind of stop that up.
And something to stick it to the sides.
Yeah, yeah.
Great. And so my last question for you is what further improvements do you think, or where do you see the future of TAVR going in terms of things to make it so that they can come in 5 minutes, be in and out and be done, or we have zero complications, right? The ideal world
Yeah,
scenario.
yeah. So something that's really interesting about TAVR is actually, and this is something that's different than most people think about. Okay, so when I think about TAVR, when most engineers think about TAVR, you think about all the mechanical things that we need to solve, right? Like, so you think of like, oh, like this thing is leaking, oh, we need to make it smaller. But something interesting that I learned recently from from sitting in on, like Edwards does, every month we do this thing called patient listening sessions, which Edwards actually brings patients in to hear what the experience of patients is. And so that's really neat because you see things in a different light. And and something that struck me was just how many times a patient has to come in to actually get their heart valve, right? So they first see their initial cardiologist, and then they get referred to like a special cardiologist who knows how to do the TAVR procedure. And once they see that TAVR procedure, the TAVR person says, okay, well, you need to come back for an echocardiogram. Okay, so they come back for an echocardiogram, they check that out, and then the next thing is, oh, you got to come back for a CT scan, right? And then they look at the CT scan and they go, okay, well, now we're going to schedule your TAVR. Well, some of these patients, maybe they live 3 or 4 hours away from these places, right? And they're going back and forth and back and forth. And so it's really, really for patients, it's really a hassle because some of them are elderly. They have to have their kids drive them to all these appointments, and back and forth, 3 hours one way and then driving back 3 hours another way. Like it's a lot of work for them. I think that if you look at there's another industry that we've seen has been pretty parallel to what we're doing now, and this is coronary bypass, right? So we saw in the 80s, where 80s and 90s, where we used to, like, coronary bypass, we used to open the heart up, like when you had stenosis in one of your coronary arteries, we would open the heart up and we would sew little PTFE, ePTFE tubes to bypass the stenosis, right? That's what we used to do in the 80s and 90s. Well, fast forward, like that whole Guidant ACS adventure and Boston Scientific, where we actually put stents in, right? So we did the exact same thing. We went through the femoral artery, and then we put this metal, like this crimped down metal thing, right? And we balloon expanded that into the stenosis to reopen those coronary arteries, right? So we saw that happen, and it was the same sort of thing where patients would have to come in, they'd have to get a CT scan, they'd have to do all this stuff. Well, now when you look at the bypass world and stenting world, you go in for an angiogram and you leave with 3 stents in the same surgery, right? So like they just got it down to such a science, and the technology is so there that they can do it. Like you can go in to evaluate, you get your evaluation, you get all your diagnostics done, and right then and there they make a decision to place the stents, right? And so if you think of the TAVR world as being analogous to that, wouldn't it be great to be able to come into a procedure and just get your diagnostics done, and boom, right away you're getting a heart valve, right? I think that would be really an exciting thing, because when you talk to patients, also another thing is the anxiety in the waiting process, right? It's like, okay, I've got aortic stenosis. I'm going to get my CT in a month. I'm going to get my echocardiogram in another month, and 6 months later, I'm finally getting my TAVR valve. And the whole time, I'm thinking about this ticking time bomb in my chest, right? And so for a patient's benefit, like to be able to get that heart valve in the next day or the same day, right away, is just would be such a great thing. And in order to do that, I think where the technology needs to go is it needs to be more flexible, right? In terms of like the sizing, like you need to be able to like look at an initial angiogram and be close enough and go, okay, we're going to put about this size in, and this particular valve is going to be adjustable in size, and we can fix it after it goes in. We can fix paravalvular leak. We can make sure we get the best what they call EOA, which is effective orifice area. But to be able to do all those things right on the spot, make decisions really quickly, would be a really great thing for the TAVR world.
Be great. So as we're finishing up here, I was wondering if you had any final thoughts for our future medical students and engineers.
Yeah. I think that one of the biggest things that we do at Edwards is we like to put the patients first, right? And so I talked a lot about these patient listening videos, which are not videos, but sessions where the patients actually come in, and we have a person interview them, and a whole bunch of people from Edwards, quality engineers, manufacturing engineers, R&D engineers, clinical people. They're all listening to the same person talking about their experience. I think that just really hearing from the patients is one really important thing. Another really important thing is to actually see procedures, because I think when you see things, it sparks things that need to be improved. And then the third thing is when we have problems in the field, we need to think about what the problem actually is. And some of the things I try to encourage the engineers that work on my teams is build models, right? Build models that replicate reality, because when you see things, it helps you to think, it helps you to understand. And the key to solving problems is understanding them. If you don't understand the problem, it's really hard to fix it.
All right. Well, thank you so much. So again, this is Sean Chow from Edwards Lifesciences. Thank you so much again. And hopefully we can save lives in the future, and we can go in 5 minutes, get our TAVR done, and it'll be variable sized, and no one will ever have to worry again. So thank you so much.
You're welcome. Thanks, Dr. King.